Hello everyone, welcome to TCTAP 2022 Satellite Symposium supported by Daewoong company. Today's topic is a new treatment strategy for hypertensive patients with dyslipidemia. Today we invited very excellent two speakers, and I'd like to introduce first speaker. First speaker is Won-jae Lee. He works in Seoul National University Bundang Hospital, and he will talk about the selection of medicine for primary prevention of cardiovascular disease, statin or aspirin. Let's show the next. Yeah. Won-jae Lee graduated Seoul National University, and now he will work associate professor in Seoul National University Bundang Hospital, and he will excellent interventional cardiology, and he'll talk about very excellent lecture about the selection of medicine for primary prevention of cardiovascular disease. Dr. Lee, are you ready?
Yes, yeah. I'm ready.
Yeah. Please.
Thank you, Chairman. Thank you, Chairman, for the nice introduction. My name is Won-jae Lee from Seoul National University Bundang Hospital. I'm going to talk about selection of medicine for primary prevention of cardiovascular disease, statin versus aspirin. So let me just talk about causes of coronary artery disease first. So basically, arteriosclerosis, I think it's cholesterol disease. Compared to normal artery, as people ages, cholesterol accumulate in the arterial wall, and it can develop narrowing of the vessel, and sometimes plaque rupture leads to myocardial infarction. However, it's not just cholesterol. So basically, there's two important factors. Arterial wall side, which I mentioned about LDL cholesterol. So to prevent this one, we can use statin, ezetimibe, or PCSK9. And there's also other sides, arterial lumen side, which is in the vessel. So it's really about platelet and coagulation. So we can use aspirin or P2Y12 inhibitors or NOAC to prevent the attack from heart and to protect heart and brain. So what are past evidences? So ICC trial, which was use of aspirin AMI, if you look at like here, compared to placebo, if you use aspirin, it's actually pretty much compared to streptokinase in terms of efficacy in the short term. Definitely, if you use both of them, you will have much more prevention for secondary event point. So after this trial, as you can see this, after 1988, the use of aspirin has been dramatically increased, and it's seemed to a lot of population that the drug must be used for cardiovascular disease. How about statin? Statin, we know that it has a great ability to reduce risk reduction, but more importantly, many studies have shown that if we use intensive statin, we can actually expect reduction of plaque volume. So based on a lot of studies using statin and ezetimibe and even PCSK9 inhibitors, we see that if we can break down the LDL cholesterol lower and lower, then we can expect the regression of arterial volume. So let me talk about aspirin first. So we have known that aspirin is a very good drug. It's useful for many people. However, there has been some recent news saying daily low aspirin no longer recommended as heart attack preventive for older adults. And the Korean news also saying aspirin long term is not effective. More than 75, there's risk of GI trouble. Let's look at the evidences. The reason why we have long been using aspirin was also evidence has good evidence. So if you look at this ASCENT trial, it's about 15,000 diabetes patients. They didn't have a baseline CV disease. If you look at this study, definitely there is a benefit. CV deaths, MI stroke, there's 12% benefit compared to placebo. However, in this trial, major bleeding was concerned, about 30%. So there is a benefit, but at the same time, there is a risk as well. Next is ARRIVE trial. This was also published in 2018. In this trial, it was 12,000 patients with a moderate risk. So like if man 55 and older having two risk factors, or woman of 50 plus, like 3 risk factors. But these patients did not have diabetes or CV disease. So if you look at this trial, bleeding risk was actually very high. It was twice much. However, the benefit was not seen in this trial. Hazard ratio 0.96, and even it was not statistically significant. Following is ESPRIT trial. This was published in NEJM in 2018, and this trial was done with patients over 70 years old. And in this trial, again, there was no benefit in primary outcome. And the worrisome part was that actually there was more deaths especially with the cancer deaths with aspirin in this trial. So if we take all the studies and do the meta-analysis, yes, there is some benefit. You can see that there is about like 19 or 20% like some benefit in ischemic stroke. However, it has a lot of harms. So hazard ratio being around 90, but hazard ratio here for harm is actually 50%, reaching 50%. So aspirin has some benefits, but we have to always think about possible harms. Let's switch gear to statin. We know that statin have a lot of pleiotropic effect, anti-inflammatory, and this is mediated with a lot of pathways. So far, statin is recommended as a primary prevention in CV disease. For example, if somebody comes to your clinic, if LDL cholesterol is more than 190, then American guidance says no risk assessment, high-intensity statin. And according to a lot of risk assessment, at the end of the day, the guidelines suggest using a statin as a primary prevention. However, aspirin is no longer recommended for all populations. So especially for people older than 70, routine use of aspirin is not recommended, and we have to always think about bleeding risk. Even in younger population, this should be considered only for people with high ASCVD risk, and of course, these patients should not have any risk of increased bleeding. So let me show some of the evidences. So you all know the Jupiter trial. In Jupiter trial, it's not patient with a very high LDL. Actually, LDL was about like 130 or lower, and people with a high CRP. But what the trial showed is that there was 44% of risk reduction, even with people with probably moderate increase of LDL. It was not just for primary endpoint, CV deaths, MI, stroke, heart endpoint were decreased. Even total death was decreased by 20%. So no doubt it was definitely positive data. Recently, there was more data with Asian people as well. So in HOPE-3 trial, published in 2016, Asian was about 50%. So similarly, moderate risk patient. So BP about 140 over 80, LDL plus 130. So patient set that we pretty much see in our daily life clinic. And this study included about 50% of Asian population. Of course, using statin gave us about 35% LDL cholesterol reduction. And what we see here is similar to what happened in the Jupiter trial. So outcomes compared to placebo, hazard ratio is about 20 or 30%, and stroke higher with 30% here, and they're all statistically significant. And more importantly, in this trial, there was subgroup analysis, and for people with hypertension, the benefit was greater with risk reduction of about 40%. So in hypertensive patient, the combination of hypertensive medicine and rosuvastatin actually reduced CV risk about 40%. And we all know that high-intensity statin actually causes new onset diabetes. But in this trial, the dose was 10 milligram, and this is a pretty big trial, but you can see that new onset diabetes was about 4%, and there was no difference between two groups. And I always put in this slide whenever I talk about LDL cholesterol. So in meta-analysis of statin RCTs, which is about 5 years of a follow-up period, we pretty much see about 20% reduction in risk. However, if we do Mendelian analysis and we take a genetic LDL score, actually lifetime benefit for statin is about 54%. Actually, it's much, much greater. Why? LDL cholesterol is going to be accumulated in your body. So let's assume that somebody's LDL cholesterol 125. Then if this person reaches about 60 years old, then there's about 5% risk of developing MI. But let's assume that we treat this patient and drug down to LDL 80. Then this patient might not get MI in their 80s or 90s. So we should not just look at the number that we see in the clinic today. We have always think about lifetime accumulation burden of LDL cholesterol. Let me talk about compliance with medication a little bit. So we know that statin withdrawal very dangerous, and actually it can cause rapid rebound and vascular dysfunction as well. So in PRISM trial, if you can hear, these are patients with ACS and history of statin withdrawal. If patient was not taking no statin, they're in the middle. If they continue to take statin, they're here. However, if they discontinue statin, their risk is actually much higher, right, like this. And actually, compared to diabetes or all other risk factors, statin discontinuation has about odds ratio of 3, which is highest even compared to other risk factors. And this is result of another trial, statin withdrawal and statin continuation. You can see that they're about 3 times more and 4 times more if you stop taking statin after MI. So we have to know that statin withdrawal actually increases cumulative mortality in patient. So these days, patient does not just have like hypertension only or diabetes only or lipid disease only. Now many patients have comorbidities having those diseases together. So you can see here in Korea in 2018, about 20% of patients actually have a 3 disease altogether. And we know that prevention of cardiovascular by polypill is very effective. So using polypill, some studies show that there can be risk reduction of 34%, and this is very dramatic actually. And we know that today's sponsor, Ulostar, is a combination of antihypertensive drug and also statin. And the benefit of this drug is that compared to other antihypertensive medication, actually olmesartan does not really have a major metabolic enzymes. And also rosuvastatin pretty much safer compared to other statin as well. So compared to other combination of polypill, we can expect better safety with this drug. And this Ulostar, this has a 2-layer of drugs, so it can also minimize physiochemical interaction as well. And this drug was study was conducted in Korea, and you can see that this is polypill. We can expect better BP control and more LDL cholesterol reduction, and also the compliance rate was actually very good. Only 9.1% in single pill compared to 20% with polypill. And also LDL improvement effect of polypill was excellent in this trial as well. So let me finish with my short case here. So patient was coming to my clinic having recurrent chest pain. And coronary CT angio showed proximal LAD 30 to 40%, some response NG, but I thought he has pretty atypical and suspect GERD. He had hypertension, diabetes, and dyslipidemia. But this patient was taking medication from cardiologist, candesartan, and all other drugs from family medicine, like diabetes, drugs, and statin as well. So I prescribed PPI, and luckily the response is very good. And I changed the medication with polypills like this, combined ARB and statin, and also combined the diabetes drug as well. So instead of taking 4 medication, patients only taking only 2 drugs, and now having much better vital sign with BP 120/80 and better LDL control. And we know that Daewoong Pharmaceutical is trying to develop these 4 combination of drugs. So nowadays we use ezetimibe a lot of times, and they're developing this ezetimibe combination. I think we can expect these drugs in 2023 and so on, and we will have much more options for treating our patient. So let me summarize my talk. Atherosclerosis, I think it's cholesterol disease, and aspirin showing benefits are relatively small considering high bleeding risk. However, we have to be very careful to risk stratification if we are to prescribe aspirin in primary prevention. And I think continued treatment for dyslipidemia is very low, but we can overcome this with giving patients who are having hypertension. And I think medicine like Orlistar, having ARB and statin together is very effective tool to prevent primary to do primary prevention is very good strategy for our patient treatment. Thank you.
Thank you very much, Dr. Lee, for excellent lecture. I'd like to introduce second speaker, and second speaker is Yongcheol Kim. He graduated Wongang University School of Medicine, and now he work in Yungin Severance Hospital, Yonsei University, and he'll talk about optimal choice for elderly hypertensive patient to prevent cardiovascular disease. Dr. Kim, please.
Thank you, Chairman. Today, I'd like to talk about the elderly patient with hypertension to prevent cardiovascular disease. This is my talk contents. Number 1, chronic disease for the elderly. Number 2, review of a STEP study, which was a randomized control trial regarding comparison between intensive and the standard BP control in patients with hypertension. Number 3, the benefit of a single pill combination, so-called SPC or polypill, regarding improving compliance shortly. Number 4, Orlomex phase 3 trial. And finally, case sharing for Orlomex family in my daily practice. Let's have a look at the chronic disease for the elderly briefly. In Korea, there is no definition of the elderly precisely, but generally it is usually defined as the elderly over the age of 65 nowadays. In 2020, Korea became an aging society because the prevalence of population age 65 or older was in 15.7%. The prevalence of hypertension is gradually increasing by age, and female patients with hypertension abruptly increased over the 50 years. In over the 70 years, about 2/3 of the population has hypertension, and that's why we have to focus on the elderly hypertensive patient. This slide you are looking at is the change of the control rate of hypertension. Interestingly, control rate of hypertension was decreasing in female patients with over the 60 years. In terms of dyslipidemia, about 50% of patients over the 50 years have dyslipidemia. It suggests that we also have to focus on the dyslipidemia in the elderly patient. In the elderly patient, smoking and drinking is decreasing by age, and the prevalence of obesity and exercise capacity is decreasing as well. So it means that the lifestyle modification strategy for hypertension and the dyslipidemia control would be very limited, especially in older patients. So we have to treat the hypertension and the dyslipidemia with medication in the elderly person. Let's move on to the trial regarding BP strategy for the elderly patient. The optimal blood pressure target for elderly patients remain uncertain because the several pivotal randomized trials show the different results regarding the comparison between the intensive and the mild BP control. So in 2008, there were 3 big randomized control trials regarding the comparison between the intensive and the standard treatment for hypertension. So HYBET trial demonstrated the benefit of intensive antihypertensive treatment in patients with over the 80 years, but JATOS and ACCORD trial did not show the benefit of the intensive BP control for the elderly. Actually, ACCORD trial focused on the patient with diabetes, but mean age was 62 years. So a code trial also suggested that standard BP control should be considered for the elderly. However, SPLINT trial supported that the intensive BP control resulted in lower rate of major cardiovascular event. So several big randomized trials show the different way to the control, and it could lead to the various BP control in the many guidelines. I'd like briefly review the SPLINT trial. The study population was 50 years or older patient at high risk for the cardiovascular event, but without diabetes. So study demonstrated that intensive BP control defined as less than 120 millimeters of mercury resulted in lower rate of primary endpoint, including myocardial infarction, acute coronary syndrome, stroke, heart failure, and cardiovascular disease. Moreover, in subgroup analysis, intensive BP control showed the benefit for very old patients over the 75 years. However, the study showed a significantly higher rate of some adverse event in the intensive BP control, such as hypotension, syncope, electrolyte abnormality, and acute renal failure. Last year, STEP trial was published in New England Journal of Medicine, and it was to find out to appropriated target systolic blood pressure for older patients with hypertension. The study was prospective multicenter randomized control trial of about 10,000 hypertensive patients between 60 and 80 years. Study population was divided in the intensive and the standard treatment group, and the mean follow-up duration was 3.3 years. Interestingly, patients were provided with olmesartan, amlodipine, and thiazide. Office BP measurement was conducted by a trained physical or physician or nurse using validated BP monitoring. Home BP monitoring system was very clever, and they used a smartphone-based application. So I think that home BP monitoring was well compared with other previous study. Regarding the medication, BP control was started with olmesartan or amlodipine or combined those drugs after randomization. Total of 8,511 patients were randomly assigned into the intensive and the standard treatment groups. Primary endpoint, as you can see, the composite of stroke, acute coronary syndrome, acute decompensated heart failure, coronary revascularization, atrial fibrillation, and cardiac death. So mean age was 66 years, and diabetes patients were included 19%, which was different study design from the SPLINT trial, because the SPLINT trial only included a hypertension patient without diabetes. Baseline characteristic was similar between two groups, and relatively from the baseline characteristics, it means that relatively healthy 60 to 80 years old patient has been registered with large-scale Asian data. So 3.3-year mean systolic blood pressure was 135.9 millimeters of mercury in standard treatment group, and 126.7 millimeters of mercury in intensive treatment group. And about half of patients were treated with CCB plus ARB combination therapy in the intensive groups. Number of medication was 1.9 in intensive group and 1.5 in the standard group, respectively. And the SPC of olmesartan and amlodipine has made it possible to achieve the target BP in healthy 60-year-old hypertensive patient. The study result was very promising. The group with target blood pressure systolic BP less than 130 millimeters of mercury is the we call the intensive BP control group, significantly lower the primary endpoint by 26% and proved the cardiovascular benefit. So it's the number of points is 3.5% versus 4.6%. This promising result led to early study termination in 3.34 years, although it was scheduled to end in the 4 years. Regarding the secondary endpoint, the group that adjusted the target BP to less than 130 millimeters of mercury significantly lower cardiovascular events such as stroke, acute coronary syndrome, heart failure, and major adverse cardiac event. The benefit of intensive treatment were consistently observed in the subgroup analysis. And the safety outcome was really important in daily practice. In previous splint trial, intensive group showed a better clinical outcome, but adverse events such as hypotension, syncope, electrolyte imbalance, or acute renal failure were increased. However, STEP trial showed the safety issue did not increase when patients with 60 to 80 years were adjusted to systolic BP less than 130 millimeters of mercury. Only hypotension was more occur in the intensive BP control group, which was reasonable, I think. So I think that it is not easy to explain the comparable safety outcome in both groups, but achievement systolic BP target of less than 130 millimeters of mercury with olmesartan therapy might lead to the getting beneficial and the safety in the fit all the patient in the STEP trial. So finally, STEP trial concluded that the intensive antihypertensive treatment targeting systolic blood pressure less than 130 millimeters of mercury resulted in a lower incidence of cardiovascular event than standard treatment in all the patients with hypertension in China. Regarding the olmesartan family, it also proved to be a safe and effective ARV for the Asian through the large-scale Asian data such as RESOLVE study for Korea, EARNEST study for Japanese. Next, I'd like to talk about the benefit of SPC shortly. The average number of pills in the elderly people in almost 4. This slide you're looking at is the status of hypertension and dyslipidemia diagnosis and the treatment. Continuous is the treatment rate is 64% in the patient with hypertension and only 34% in patient with dyslipidemia. So I guess that most of these diseases are asymptomatic, so patients don't have to keep especially medication for the dyslipidemia. Therefore, single pill combination strategy is mandatory, especially in the elderly patient, because SPC definitely increased the medication compliance by 44%. That's why Olomax family was developed by Daewoong. Olomax family is the first SPC of olmesartan, amlodipine, and rosuvastatin combination in Korea, developed by Daewoong with its own technology. So tablet size is under the 10 millimeters. Compared with other SPC tablet, Olomax family is the relatively small size to easy swallowing, especially for the elderly person. A larger study, multicenter, randomized, double-blind phase 3 clinical trial was to evaluate of the treatment effect and the safety of Olomex family. Compared with olmesartan plus rosuvastatin, Olomex showed the benefit of BP lowering effect, and compared with olmesartan plus amlodipine, Olomex showed the benefit of the LDL lowering effect as well. Moreover, Olomex showed the improvement of the other lipid profile, including decreasing total cholesterol and TG and increasing HDL level. Lastly, I'd like to share one of my cases regarding how to use the Olomex family in my practice. 78-year-old female patient visited my clinic due to uncontrolled BP from the local clinic. So local medication was ARB, beta blocker, and rosuvastatin, but office BP was 167, 98 millimeters of mercury. So I changed the antihypertensive medication Sevica family and the indapamide, and additionally beta blocker, and 1 week's follow was planned. Echo showed a good LV ejection fraction without LV hypertrophy. 1 week later, blood pressure was stable using new medication, including Sevica family, and the LDL level was the 90 by rosuvastatin 10 milligram. So I changed the Sevica and additional rosuvastatin to Olomex family. 1 month later, office BP and home BP was very stable, but hypokalemia was observed, so indapamide was stopped. 3 months later, office BP and home BP was very stable, and the LDL level was quite good. So patient and I were really happy with control BP without any safety concern. So this is one of my typical case regarding how to approach the older patient with uncontrolled BP using Sevica and Olomex family. This is the last slide on my presentation. Among the chronic disease in the elderly patient, hypertension and dyslipidemia are most frequent. STEP study confirmed that intensive BP treatment for the Asian patient aged 60 or older is a way to reduce the cardiovascular event, but not increase the major side effect. Olmesartan demonstrated potential effectiveness and safety in the 3 major Asian countries, Korea, Japan, and China. And the risk of cardiovascular event can be reduced by improved medication compliance through the SPC, or another name is polypill. Olomex showed significantly blood pressure dropping and improvement in the lipid level in the 3-phase domestic multicenter clinical study of hypertension patient with dyslipidemia. Thank you for your attention.
Thank you very much, Dr. Kim, for excellent lecture. Now we have a Q&A session. I have one question for Dr. Lee, Wenji Lee. You mentioned aspirin has benefit, but always we think about harmful, especially GI bleeding. And so my question is the diabetes mellitus patient with previous cardiovascular disease history, and he take the low dose aspirin, but he did not take the statin. So that kind of patient, do you think about the change of the prescription?
So if patient previous disease, then I think I will continue on aspirin, and especially in the SEN trial, diabetes patient was benefiting from aspirin. So in this case, then I will just add statin to aspirin.
Okay, thank you very much. And the this satellite symposium sponsored the company make the polypill treated the hypertension and dyslipidemia, and you also showed the prescription of the polypill for hypertension and dyslipidemia patients. How about the patient satisfaction about the polypill?
So I think the benefit of polypill is greater when patients are taking more drugs. Maybe just 2 drugs and change it to 1, they won't benefit too much. But still, I think more important in this factor is that patients are they know that they should take hypertensive drugs. Because when they come to clinic, they see the numbers. But LDL cholesterol, we don't always measure it. And they think if it's dropped, then they think it's okay. So we see a lot of patients stopping statin once they think, and they also think that if they eat less and do something, and they can decrease their cholesterol, and if they take omega-3, then they can decrease. So there are many ideas about cholesterol drugs. So a lot of times they stop it. But if we give it just single pill, then it's still a single pill. So I think it's very good for continued medication.
You mentioned a very important point. So patient doesn't know this drug is a hypertensive drug, this drug is a dyslipidemia drug. Very, very important. And also, you are talking especially about statin withdrawal.
Yes.
Very, very important concept, and very, but many patients and also even some doctor withdraw the statin. So how about you think about the statin withdrawal is very, very dangerous or not dangerous?
So I think it's even more dangerous compared to even naive patients. So we don't know exactly the mechanisms yet, but statin improves a lot of vascular functions as well, anti-inflammatory and everything. Stopping it even reverse the situation, and maybe it gets worse than before. So I think it's very dangerous stopping statin, and it's already actually very well known. And even this LDL cholesterol variability is also very harmful for patients as well. So we have the data. So I think stopping statin should not be considered in any situation.
Okay, thank you very much for excellent Q&A for statin and aspirin and also polypill. And also I'd like to ask to Dr. Kim, and you talk about the optimal choice for elderly patient.
Yes.
So I think in Korea, elderly patient population is increased very rapidly. So but we don't know exactly how about the target of the blood pressure, especially over 70 years old patients. So do you think the over 70 years old patient with hypertension, how about the optimal target of that kind of patient?
Yeah, that is a very tricky question, and it's very difficult question. So we have the data, recently data is intensive BP control in the elderly patient to give the more beneficial for the patient. But the other things is we have to think about the daily practice. So it's many elderly patients complain there is also static hypotension when they BP antihypertensive medication is increased. So I strongly recommend the home BP check. Every patient is coming to our OPD. So it's patient is if the patient is BP is very stable, but he or she suffered orthostatic hypotension. So I think is decreased is the medication is necessary, because it's the orthostatic hypertension symptom. If the frequent is patient is want to stop the blood pressure medication, but if they don't have any safety issue for hypertension or dizziness. So I try to keep medication to the intensive BP control. Is from the STEP trial is less than 130 millimeters of mercury.
Thank you very much. And you talk about the home BP. I think the home BP is very, very important for control of the blood pressure for hypertension patient. Do you know in Korea home BP monitoring? How can patient home BP monitoring and how you recommend home BP measurement for patient?
Almost every my patient, including patient who perform the PCI or hypertensive patient, is I always recommend this home BP is very, very important for you and your family. So it's in our hospital is we can patient get is BP monitoring just $50 US. Yeah, and then we supply the blood pressure measurement book is made by myself. So it's every single time they send out the BP book to me. So we talk about very short time, but we will talk about that in discussion whether your BP is good or not. Because OPS BP is the number of about almost 30% of patient is increased in the OPS BP, although their blood pressure is very stable in the home. So that's why I always recommend this home BP. Yes.
So you mean home BP is measured by himself, right?
Yeah, because in our BP measurement book, we very detailed description is how to measurement is BP. For example, in the morning within the 1 hour after back to the hospital, back to the toilet is that they should check the BP, and the nighttime is every time is okay. So they don't they very, very easy to follow the method. Yeah.
Okay, thank you. And Olomax has 3 components
Yes.
of polypill, right?
Yes.
And so you prescribe. You also showed the Olomax patient case, and the patient showed a significant blood pressure decrease and also lipid profile improvement. So, how frequently you prescribe that kind of 3 different mixed polypill, Olomax, for your patient?
All my patient.
All.
That means when the patient coming to my clinic is the first time I explain this potentially you need this hypertension medication, and this half of hypertension patient is related to the dyslipidemia. So it's before this next time clinic, I firstly comment is next time I think you need is dyslipidemia medication. So that is very useful for the elderly patient and is a young patient as well, because it's a young patient never ever want to is additional medication. So it's just a single one one SPC is always contained is 2 antihypertensive drug and dyslipidemia. So that's why I think it's within 6 months or 1 year is all of my tablet is just changed this one tablet. Yeah.
Okay. Two speakers already talking about polypill has benefited for compared to single pill, right? So any comment or any talking about today's topic new treatment strategy for hypertension patient with dyslipidemia. Dr. Lee, any comment or?
So I think we have very good tools now, SPC, and it's not just 2 drugs now, 3 drugs, and I showed that even 4 drugs is prepared. Especially, so since we are all intervention cardiologists, we always want to drag the LDL cholesterol a lot, and sometimes just statin is not enough. So the times when I can use this like oral max is that I want to use ezetimibe, but I can't use because of it's not there. So I think from now on, it's going to be great if we can have this like 4 combination. Then we can also use these drugs even in very high risk patients as well.
Okay.
I
How
have
about
no,
Dr.
I
Kim?
have no comment. I fully agree with this, Professor Lee. Yeah.
Okay. Thank you very much. So I think that these 2 speakers, today's topic is very, very important for patient treatment for hypertension and dyslipidemia. I think that hypertension and dyslipidemia are over 40 or over 50 years old old patient has always have hypertension and also dyslipidemia. So these 2 are very, very important for patient health and also but the treatment and target goal achievement is very, very low. Even we used several different drugs, but I think the polypill used very, very improvement target goal achievement. So I think that these today's 2 speakers lecture are very helpful for hypertension and dyslipidemia patient treatment, and especially also very elderly patient. Thank you very much for watching the satellite symposium organized by CVRF and supported by educational grant from Daewoong company. I'd like to thank you all the 2 speakers also, and I'd like to close today's satellite symposium. Thank you very much.